Okay, well, welcome everyone to our latest Journal Club, and thanks for taking the time to be with the AAMS and hopefully learn something tonight. The topic is very interesting and very relatable to pretty much every specialty. Sepsis, more importantly, identification and management, and really everyone in the medical field needs to be aware of this and needs to know these details. So hopefully it will be a great educational experience for everyone. We have two speakers today. They're both called Nora for whatever reason, but Nora Martini-Lujura is the presenter. She's currently a second-year internal medicine resident at St. John's Riverside Hospital in Yonkers. She was originally a chemistry major at St. Francis College in downtown Brooklyn, and then proceeded to attain her Master's of Science in Pharmacology from Tulane University in New Orleans, before coming back to New York City and getting her MD at Touro College of Osteopathic Medicine. So Nora's professional interests include critical care medicine and cardiac electrophysiology. And outside of medicine, with whatever time she has, apparently, she enjoys cooking and spending time with her family. Thankfully, she has been drawn to AAMS because it encompasses both her strong love for her heritage and obviously her profession as well. So thank you very much, Nora, for doing the work and sharing your presentation with us. We're going to have the other Nora, Dr. Gashi, who's also the president of AAMS. And as Dr. Chausha mentioned, she was reelected for another 2-year term. So congratulations. And thanks for being our president. She will be moderating the talk, and Dr. Gashi is a graduate of the University of Pristina School of Medicine in Kosovo. She completed internship training at the National University Hospital of Kosovo and residency in internal medicine at Beth Israel Medical Center in New York. This was, do you want to say it? 2009. For over a decade, she has practiced primary care and hospital medicine in the community setting all over the US, from New York, New Jersey, all the way to Hawaii. And she maintains her certification and licensing credentials in her specialty. And again, she's our beloved president. So without further ado, I'm going to hand over the microphone to Nora, the first Nora, Dr. Martini-Lujura, so she can take over the presentation. Thank you again, everyone, for joining us.
Thank you, Lawrence. We have a little, we kind of gonna change it this time. I'm gonna start the presentation.
Excellent.
Okay.
I see.
So it's still Nora, it's just a different Nora.
It's a different Nora. So we're gonna do this back and forth. Don't mix us up.
So we can have Nora 1 and Nora 2.
There you go.
That. Yeah, sure.
There you go. And
Well,
Jurgen, there's only one Jurgen.
There's only one Jurgen. One and only. Well, thank you, Lawrence, for for kind words, and I'm so happy to be in the other side of the Journal Club, and I'm happy to present this. Hopefully, we'll learn something today, and we can share. I would like to be it as interactive as possible. I'm gonna need surgeons around because I want their opinion, and I'm going to start with a case presentation. That's why I took it over, like with me starting first, and then Nora will continue with the sepsis guidelines, management, and treatment. Okay. So let me just, sorry. I'm trying to, okay, I think I got it right.
Share screen.
All right. Huh? Oh, I didn't share it? Okay, yeah. It's
There we
good?
go. Got it.
Yeah.
Okay. So,
Excellent.
yeah. So we're going to start with case presentation, and perhaps like we come back after Nora presents the guidelines, and we can come back to my case presentation and talk about it. But yeah, I mean, you can interrupt me, you can ask me question. I didn't put everything in it, you know, I just try to be as brief as possible. I had this case about 2 months ago. I actually inherited from my colleague the last day, but I thought it was interesting to present it with tonight's subject, the topic. So cellulitis and sepsis. This is chief complaint, severe leg pain, swelling and redness, cannot walk. So this is a 45-year-old obese male who presented to ER with redness, presented to ER with worsening of pain in the left groin and upper thigh over the last 4 to 5 days. He has history of uncontrolled insulin-dependent diabetes, history of chronic hidradenitis with chronic drainage from skin, sinuses, including axilla, mammary folds, and both groins. And he was on antibiotic prophylaxis. Also reports fever, chills, GI upset with nausea, vomiting, poor oral intake. But his mental status was intact. Past medical history, insulin-dependent diabetes, which was uncontrolled, hidradenitis suppurativa, stage 3, hyperlipidemia, anxiety and depression, degenerative vertebral disc disease, chronic diabetic lower extremity ulcerations, electrolyte abnormalities, including vitamin D deficiency, venostasis congestion, and dependent edema bilaterally. Surgical history, pilonidal cyst removal, social history, active smoker, no alcohol, no drugs. So management and treatment in ER, patient arrived in ER at 9:45 p.m. His vital signs were blood pressure 100/66, heart rate of 129, respiration 28, O2 sats were 100%, no fever. He had pain 10 out of 10, and he weighed 161 kilogram, BMI of 50. On physical exam, and this is based on ER notes, patient appears ill, in severe pain, diaphoretic. Rash present on the left thigh. There was warmth, induration, weeping, tenderness, and thickening. There's inflammation. Laboratory data, WN38, creatinine of 1.89, sodium 125, potassium 3.0, albumin 1.4, ALP 175, glucose of 543, lactic acid of 4.4, A1C it's more than 16, and beta hydroxybutyrate 0.80. And the cutoff is 0.4. White blood cell of 19.5 and HNH 10.6 and 32.3. EKG, no acute SDT wave changes. At 10:34, patient received a normal saline 1 liter of bolus, followed by 3 liter bolus of NS. At 11:20 p.m., he received IV antibiotics, some hydromorphone, regular insulin, and the repeat vital signs were blood pressure 112/70, heart rate of 111, respiration of 20, and O2 sat of 91%. He moved to the floor. He was feeling better at the time, pain control, and afebrile. Day number 1, this was on the floor. Vital signs were pretty stable, heart rate of 72, respiration 20. He was on 1 liter oxygen, 94%. On exam, alert and awake, oriented ×3, pain controlled, eating and drinking, feeling better. On the skin exam, this is what I saw, but I put it in here even though I saw him on day 2. So this is an obese male with multiple skin lesions, sinuses in bilateral axilla, under the breast, purulent drainage in the left axilla and in the fold under his pannus. His disease was quite advanced, erythema of the entire genitalia and growing again with purulent drainage on both sides. Top of the left thigh, significant tenderness and edema in the tissue with some induration. UN and creatinine 38 and 1.71. Overall, everything
Surgery
looks
was
better.
surgery was not consulted in the emergency room?
No, surgery
Okay.
was not consulted. Blood culture were drawn in emergency room and showed some bacteria alert in anaerobic bottle. But when I checked like 5 days after, there was no growth. And wound culture showed strep galactolyticus. On floor was stored vancomycin and meropenem, continued IV fluid, normal saline, and surgery was consulted that day. So surgery did IND of the left upper thigh, and there was some serous drainage, no frank pus noted, and the wound was packed. Day number 2, right? This is where
Stop, with all due respect, when surgery saw the patient, they examined the leg 360 degrees, going from the perineum, laterally, scrotum, groin, and looked at the entire leg, not just the anterior surface.
the entire leg, yes.
Okay.
They looked at the entire leg, and she was, she did IND at the bed because there was, I don't know, OR was not available or something. So, but she did that, and she said she didn't get anything out of it.
Yep, that's standard. Okay.
Yeah. So this is day number 2. I was asked to see a patient early morning, patient diaphoretic, flushed, confused, hallucinating. Blood pressure was 106/52, heart rate of 122, respiration 24, and temperature of 101.1. And laboratory data, BUN and creatinine, we saw rise, 48 and 1.95, sodium 129, lactic acid was 1.2, glucose 277, CRP 301, and white blood cell 12. And he presented with white blood cell of 19. So at this point, right, I consulted surgery because this hospital is affiliated with Dartmouth Hospital. So I consulted surgery, I consulted infectious disease, and just to see what's their opinion. And they said to continue and do the CAT scan, even though creatinine was elevated. So they said to do the CAT scan with IV contrast. And this is what we found, partially visualized cellulitis and subcutaneous emphysema in the proximal left thigh. There was no organized fluid collection. There are flags of air within peritoneum and also the medial right thigh. Constellation of findings is concerning of Fournier's gangrene, partially visualized cellulitis and subcutaneous emphysema in the proximal left thigh. No organized fluid collection is identified. There are flags of air within the peritoneum and also the medial right thigh. And yeah, and I took like a couple of pictures. So these are the CAT scan, and you can see the air. So I guess this is the air that we're talking about a little bit here. What do you think, Dr. Choshai? This is where I need your help.
To me, this is a surgical emergency.
Yeah.
This patient needs to go to the operating room because this patient has Fournier's gangrene and requires radical debridement of the underlying tissue. And if they don't get it, they will die.
Yeah, and that's what happened. I transferred the patient to Dartmouth, and he went like with a helicopter actually, and they took him right away. So yeah, it was interesting.
Why wasn't surgery debridement, and what did they IND?
Well,
didn't understand.
the errors are several-fold. One, a patient with this body habitus should have gotten a CAT scan on admission, number one. Number two, the examination is often faulty on admission because they don't often look at 360 degrees. And number three, they should be very aggressive to see if there's improvement that is significant that occurs within the first 36 hours. And when they saw a hallucinating patient, they should have known they had overwhelming sepsis to deal with and had to deal with source control to save this patient's life.
Yeah, I mean, as soon as we saw he's hallucinating, we did CAT scan, and this is what was found, and that's when I called surgery.
You did everything right. I'm just,
Yeah.
I apologize for my colleagues in surgery. They did everything wrong.
Yeah, I think
Yeah,
surgery missed here. The other question I had, I'm surprised to hear that emergency room didn't scan him. They scan everybody. How did he escape without a CAT scan?
You know what's interesting? Because I think at the time is when the IV contrast was shortage.
And he's
Right,
morbidly
but I mean,
obese.
even without IV contrast, they would be able to see everything, emphysema,
morbid-
gas,
and he-
everything that will be needed.
No,
Not that I'm excusing surgery, but
I'm not excusing either. Yeah.
He's
the
morbidly
issue
obese.
is, yeah, so the issue is if it's, the problem is when you have morbidly obese patients, Dr. Chausha say, a lot of time the exam is not very thorough, and sometimes you can't even tell. And that's kind of the problem with necrotizing fasciitis, Fournier's gangrene, unless you're really, kind of deliberate and thorough, you're not going to necessarily see unless it's like a florid, necrotic tissue looking at you.
And the radiologist and the ER guy don't want to send them for a CAT scan.
Yeah, that's surprising to me. I mean,
they think
everybody
it's a
with a
pain in the
freaking
ass.
broken toe gets a CAT scan here. So I'm not sure why
Yeah.
they didn't. But the other thing I was going to say is when you have patients like this, uncontrolled diabetes,
Mhm.
signs of a sepsis, especially another typical laboratory finding that's found is hyponatremia. Those patients have a infectious / necrotic type of source until proven otherwise. And especially with this patient who had a localized, symptomatic issue by the thigh, groin, close to the perineal area, he's got Fournier's. I mean, almost at presentation.
The
Yeah.
question I have for you, Nora, is were they able to save his leg, or did they have to disarticulate the leg?
Well, all I know, he went there, he went to surgery, and then ICU, which I could not, contact them, and I had no mode of communicating with them. So,
Because the concern I have with air in the peritoneum and contralateral air in the right thigh, that they may have aggressively treated him with a amputation at the level of the hip.
oh,
and-
wow.
And may
Hopefully
have,
not.
hopefully not, but it's been
Yeah.
done. It's been done.
It has been
And-
done. I agree. Yeah, I've seen it.
And then done drainage on the right, and then observed with antibiotics, the pneumoperitoneum, and hoped that improved. Otherwise, he would have had to be explored as well, laparoscopically or open.
Yeah.
But the guys at Dartmouth are actually very good, and they would have been very aggressive.
Yeah. I have a question. So, is it that when you start IV antibiotics, then, the symptoms can get even worse, and that's when, you have to start doing something about it? Because he got better before he got worse.
Yeah.
I don't think so.
It doesn't really help. It doesn't, it may mask things for 12 hours, but
Yeah.
when you see this, it's a clinical diagnosis that requires immediate response. This is a surgical emergency. He should have had a surgical consultation on admission, and the surgeons on admission should have recognized the seriousness of his problems, and he should have been in the ICU from day one, day get-go. And if he hadn't improved within 12 to 24 hours, he should have been on his way to the operating room for a massive opening of his tissues on the leg to expose the underlying pathophysiology.
Right.
Yeah, no, the antibiotics are not going to make this worse, but they will definitely not make this better.
Yeah.
This problem. The problem is you have a bacteria, or usually an anaerobic bacteria, that is basically destroying his tissues and following tissue planes, tracking and moving forward. If significant portion of his body gets involved, he is not salvageable. This diagnosis has a 50% mortality rate.
Exactly.
And that is with, everything being done, meaning that, there's a very good chance that even if you do aggressive surgery, these patients don't survive.
That's correct.
Because that is a, like Dr. Chausha said, this is a surgical emergency. This is actually worse than somebody having free air when they show up to the emergency room.
That's correct.
Um,
And this
because
leads
it's,
us to the topic of our talk,
yeah,
because here you have a septic phenomenon that requires all modalities, surgical, antibiotic, critical care, fluid, to get source control. And if you
Right.
don't
Yeah.
get source control, the patient dies.
yep.
Yeah.
It's a thankfully rare, but it does happen occasionally. And this is actually the most typical patient to get this diagnosis on. A obese patient, uncontrolled diabetes, having these vague symptoms of, pain here, ache there. And sometimes, especially in the beginning, labs are not very, very impressive, or, you don't really find anything too concerning when you first look at it. But these are the type of patients that you can lose in 24 hours.
And
Yeah.
then when we save them, Nora, they're
Mhm.
often sitting there with their testicles exposed,
Yeah.
their muscles
Yeah.
exposed.
Everything's
They're in the hospital for at least a month,
Uh-huh.
Yeah.
getting plastic surgical closures and
Uh-huh.
Yeah.
treated by a variety of services. And the
Yeah.
quality of life thereafter is never quite as good as it was once. And although these people don't really have an excellent quality of life, but whatever their quality of life was, it never returned to that. It's actually quite abysmal.
Yeah.
Try to put a wound vac on that groin, Dr. Charushai.
Yeah, absolutely, buddy. You'll be putting hundreds of wood crabs on those grounds.
You're gonna have to put a vac over his whole body shortly.
But with all seriousness, I mean, this is the great masquerader of the, deadly cellulitis or neck fash, the Fourniers. 20% of them, and I think that's what fooled our physicians. They have a normal lactate. What I've given away on this lady is like the previous history of infestation with MRSA, the hidradenitis, the pilonidal cysts. Every time I see a diabetic, obese history of draining hidradenitis, I think of her living with MRSA. And when they come septic like that, such as a heart rate and borderline hypotension, then I think of a neck fash. You don't really see it clinically unless there's like bullae on the skin and crepitus on palpation, which is hard to see on an obese patient. And as someone else said, it's like it spreads on fascial planes, so it's hard to see unless you get a CAT scan. You see the air. Another thing about the antibiotics is not that they get better or worse; it's that they live in a borderline hemodynamic status. And once you induce them on the gen anesthesia, that's where they collapse. So they go down south, and they're before
That's
you know,
right.
they're on 3 pressors before you make the incision.
Yeah.
Could you expand a little bit about the association between MRSA and these people?
Well, I don't know if, the fact they do have chronic soft tissue infections, and it manifests itself with the, I don't know if it's a combination of personal hygiene, diabetes, obesity, but it all correlates. It starts.
Okay. Because I wasn't aware of MRSA being a direct correlate, but what you're saying, it's a confounding factor. Okay,
Correct.
that makes sense. Very good. Now I understand you.
Okay. So we're gonna continue. Any more? Should we continue with the presentation? Nora is waiting.
Nora, great case. Nora 1, great case.
Oh, thank you. Thank you.
Great
I
example.
thought it would be interesting for this subject. All right, I'm gonna stop sharing, and Nora, you can take it over.
Nora 2.
Okay,
Nora
great.
2.
Thank you, Nora 1. So, so thank you for that case. I think it's a really good segue into the topic. So we're going to be talking about sepsis identification management. I'm going to be using the Surviving Sepsis Guidelines, the 2021 revision, to kind of do a brief overview of what should we do when we get these patients? How do we recognize the severity of these patients when they come in? And what's the, evidence-based appropriate steps that we should be taking in order to manage and treat these patients. I am going to try to share my screen. It says, let me see. Let me know if you see it. I have to just allow access. Sorry.
You can do this.
I can do this. I believe it.
Even after spending time in New Orleans, drinking hurricanes, I'm sure you can do this. Nora, too, did you ever have one hurricane at Pat O'Brien's? She's not even listening to me. I can't even get her. I can't even get her. Wow. I can usually annoy most women within 30 seconds.
We cannot hear you, Nora.
And gratefully, she can't hear me. Yeah.
All right. I think they're
cannot
trying
hear
to.
you, Nora.
Nora, you're playing for the Red Sox. We can't hear you, and I'm a Yankee fan.
All right, so she left, so she'll be back. I'll put
Okay.
the reset.
Eddie, how are you? I haven't seen you in a while, and you're like you. Nobody has photographs anymore, or even pictures, or in life. They just sign in and then go play with their dog for an hour and come back. We know what's going on, just so you know.
I'm still at work dictating my
They kicked
notes.
me out. Sorry,
Nora,
guys.
too, are you back?
Yep, we
I'm
can
back.
hear you now.
I got kicked out in order to share. It looks like I had to get kicked out, unfortunately. So I'm going to be sharing my screen. Hopefully you guys can see it now.
There
Are
we
we
go.
doing better? It's up.
Yes.
Yeah, there you go.
Excellent. Yay. Finally. So
We just assumed there were too many hurricanes at Pat O'Brien's.
no, I somehow managed to not only survive New Orleans, but make it out sober and with a degree.
You're much
So,
better than I am. That's for sure.
Yeah. All right. So we are going to be talking about sepsis identification and management. There's 92 recommendations total, some new, some old. We're not going to go through every single one of them. The goal is really just to kind of summarize the key recommendations, changes to the guidelines using the 2021 revised surviving sepsis guidelines. Also, just to give a refresher to everyone on the topic, since it's relevant across all different specialties. Without further ado. So definitions. Sepsis is a life-threatening organ dysfunction. It's caused by a dysregulated host response to infection. What are the main characteristics of sepsis? So you need to have dysregulation of anti-inflammatory versus pro-inflammatory mediators, and you have to have dysregulation of coagulation in the microvasculature of the body. Septic shock versus sepsis is profound circulatory, cellular, and metabolic abnormalities despite initial fluid resuscitation. It's associated with a greater risk for mortality than sepsis without shock. The characteristics are high cardiac output, which is seen early on, that may become depressed later on with a low systemic vascular resistance. Epidemiology, this part's a little bit hard to kind of talk about because it's really difficult to determine. The definitions are always changing. The guidelines are always being updated. There's not a centralized reporting system, and there's often clinical misdiagnosis, underdiagnosis. Sometimes things like the case that we saw initially on presentation to the ER didn't come in, and we didn't say it was sepsis right away. We kind of find that out later. So that makes epidemiology pretty difficult. But what do we know? So we do know that there's disparities amongst different demographic groups. There's an increased incidence in the older population. Specifically, the incidence actually increases each year after age 65. Mortality is really high in sepsis. It's one of the reasons why this is such an important topic. Patients who are septic have a mortality rate that's at least, if not more, 4 times greater than that same patient that has the same underlying conditions and the same comorbidities who's not septic. Mortality increases by about 15% for each sepsis-related organ system failure. So diagnosing organ dysfunction, how do we do that? Currently, we're using the SOFA score, which is sequential organ failure assessment. We use this to assess patients that are in the ICU setting. It gives you a score of 0 to 4 for each of the 6 organ systems. So respiratory, coagulation, hepatic, cardiovascular, central nervous system, and renal. Acute organ dysfunction is indicated if your initial SOFA score is 2 or greater, or if you have an increase in your SOFA score of at least 2 or more. This predicts your in-hospital mortality of being greater than 10%. So guidelines actually are currently recommending against using QSOFA when compared with, sorry, that's a little typo, when compared with NEWS, SIRS plus infection, or as a single assessment screening tool for sepsis or septic shock. So I like this table. It just kind of gives you what is the SOFA score, how do we assign these points, or you could just open up MD-Calc and do it that way. But just to kind of give you guys an idea about what the SOFA score looks like. So diagnosing septic shock, what are the criteria? You have to have hypotension requiring vasopressors to maintain a MAP of at least greater than 65 and a serum lactate of greater than 2 milliequivalents per liter, despite adequate fluid resuscitation. If you have a patient who is diagnosed with septic shock, it's associated with at least a 40% risk for in-hospital mortality. So already you have this patient that's coming with septic shock. It's severe, and we need to get going if we haven't started treating that patient already. So what is the management then is the question. There's 2 main goals of management. Number 1, we want to control that infection. And number 2, we want to support organ perfusion. This is kind of where we're going to start getting into more of the nitty gritty of the surviving sepsis guidelines. So bear with me a little bit. The 1 hour bundle is kind of the goal of what we're trying to do. So what is the 1 hour bundle? Within that initial hour that patient's coming in and we recognize that this is sepsis, we want to collect blood cultures, serum lactate levels, initiate broad spectrum antibiotics, administer IV fluids with or without vasopressors, depending on whether or not the patient is in shock. And that is the mainstay of the bundle. So fluid resuscitation. This one's a little bit controversial right now. We're going to talk about the surviving sepsis guidelines, although I know that there has been some things that have come out that are kind of contraindicating some of the things in the guidelines. But as of right now, the guidelines say that we have to begin fluid resuscitation immediately. If you have a patient with septic shock or sepsis-related hyperperfusion, you have to give at least 30 mils per kg of IV crystalloid fluid, so LR instead of NS. And this should be given within the first 3 hours of resuscitation. This was a strong recommendation in the old 2016 guidelines. It's now been moved to a weak recommendation in 2021 because of some of that evidence that is coming out about how much fluids is actually considered appropriate in these patients. What is new in 2021 guidelines? So in patients that have septic shock, we can actually use capillary refill now as an adjunctive tool to guide measured level of perfusion. Not that we couldn't use it before, but it's just now a recommendation that wasn't in that initial 2016 recommendation. Balanced crystalloids are better than normal saline for resuscitation. Use serum lactate as a measure of guiding fluid resuscitation. The goal is to lower lactate levels. This is a weak recommendation still. It's not a strong recommendation, but it's something that you're going to see often in clinical practice. Albumin is recommended for patients who have received large volume of crystalloids. And we are now actually seeing that they're recommending against starches and gelatin for resuscitation. Vasopressors. Your MAP goal is going to be greater than 65 for patients with septic shock who are on pressors. You want to now start vasopressors peripherally. We can give them for up to 24 hours if needed, instead of delaying the initiation of pressors in order to obtain central venous access. Your first line vasopressor is going to be norepinephrine. That hasn't changed from the old guidelines. You add vasopressin instead of escalating the dose of norepinephrine, and your third pressor is going to be epinephrine. For patients that require epinephrine in addition to norepi and vasopressin.
What did you say? Could you repeat that last statement? I didn't hear it quite well.
Oh, your third pressor is going to be epinephrine in patients that are still septic, that are maintaining that MAP of at least 65, even though they've already been on norepinephrine and vasopressor. When they are recommending to add vasopressin instead of increasing the norepinephrine, we don't want to be maxed out on norepinephrine prior to adding that vasopressin. We want to add that in earlier on, around when we're about 15 to 17 units prior to adding in the vasopressin. So that gives us a little bit more room to titrate the norepinephrine up before we kind of get to that third point of adding epi.
I thought my understanding was that was a weak recommendation. Is that a strong recommendation?
So the strong recommendation is to start with the norepinephrine. If I believe it's, I have to double check whether it's strong or weak to add in vasopressin prior to maxing out on Levophed, but I believe that I have to double check. So don't.
Okay.
But I think it's strong to add vasopressin prior to maxing out on Levophed, so that you have more room for adjusting your Levophed.
Okay.
But I have to check. I'm not 100% sure, honestly.
I'm not sure we do that, but okay. That makes sense.
Clinically, I know that in my hospital, we do that. I don't know whether it's a strong or a weak recommendation. I would have to double check.
Yeah, that's okay. Sorry to interrupt you. I
No,
apologize.
it's okay. No, that's fine. That's what this is for. So continuing with the recommendations, you want to avoid terlipressin. Again, you don't want to use it in patients with septic shock. If the patient does have septic shock, cardiac dysfunction, and they're still showing signs of inadequate perfusion despite that adequate arterial blood pressure and volume status, we want to add dobutamine to these patients in addition to norepinephrine, or we can use epinephrine alone. And also recommended not to use levosimendan. Sorry, I can't pronounce that right. Okay, I just really like this chart. Is kind of a quick summary about everything that we've talked about. So this actually, Dr. Chayoshai, gives you the answer to what we were talking about before. So consider adding vasopressin if the MAP is low to moderate, is still a weak recommendation. The two main strong recommendations are using that norepinephrine as a first line vasopressor, as well as keeping that MAP of at least 65. I believe some of the evidence that's coming from using vasopressin before reaching that max of norepi is because of all of the peripheral vasoconstriction and people losing their digits and everything, even though we see a lot more GI vasoconstriction with the vasopressin. So it's kind of like a fine balance. So next is source identification and control. This part is really, really important. Basically, you identify the source, and how do we do that? Blood cultures, wound cultures, if appropriate, chest X-ray, UA, et cetera. And by et cetera, I mean, if you think there's something there, try and identify it with whatever means necessary. So for this patient that we think the sepsis is originating from that pannus, right underneath that pannus, CT would have been appropriate, blood cultures, wound cultures is appropriate. Once you've identified the source, basically get it out. So if you have a catheter and you think that's the source of infection, remove it. If you have an abscess, drain it. One important exception is necrotizing pancreatitis. You should hold off on resection or drainage of that until your margins of necrosis are completely clear, so that you avoid worsening the necrotizing pancreatitis.
Even that's controversial.
Yeah. So your best practice statement for antimicrobials, this is kind of what they're coming out and saying is what we should do. For adults with suspected sepsis or septic shock, but there's unconfirmed infection, surviving sepsis guidelines still recommend continuously reevaluating and searching for an alternative diagnosis and discontinuing empiric antimicrobials if there's an alternative cause of illness is demonstrated or strongly suspected. And so the evidence behind this statement is in this table. I really like this table. It shows that there's actually no difference in outcomes between patients that are treated with empirical antimicrobial therapy when they're treated with a shorter versus longer duration of therapy. This was based on RCT systemic reviews in patients that had pneumonia, bacteremia, intra-abdominal infections, and UTIs. So key changes in the guidelines of antimicrobial therapy in septic and septic shock patients. So we want to administer antibiotics within 1 hour of recognition of sepsis or septic shock. Previously, they said administer as soon as possible. For patients with possible sepsis but not shock, we should administer antimicrobials within the first 3 hours. If the patient has a low likelihood of infection without shock, we should defer antimicrobials and monitor them closely. And there's currently no recommendation for the use of antiviral agents. This has become more of a hot topic recently with the COVID infection, so evidence is still coming out. They haven't come out with official recommendations yet. The most common pathogens are gram-negative, gram-positive, and mixed bacterial pathogens when we're talking about septic patients. So you want to select broad empiric antibiotics that cover what's most common, and then you're going to adjust as the cultures grow back. Some things to consider when you're looking at these antibiotic choices and your patient is, what is the patient's history? What is their source of infection? What's your local antibacterial resistance pattern? Does the patient have recent antibiotic use, recent hospitalization? Things, are we thinking MRSA? Are we thinking ESBL? Things like that when we're picking what antimicrobial is appropriate for the patient. Your initial antibiotic recommendations in a septic patient are going to be carbapenem or an extended range penicillin or beta-lactamase inhibitor. If your patient is coming in with septic shock, you're going to do combination with at least 2 antibiotics from different classes that are addressing the most likely culprit. Like I said, we want to tailor that based on what is our patient presenting with, what is our patient telling us. If there are specific risks for antibiotic resistance, so MRSA, like we were talking about before, empiric antibiotics with coverage for resistant gram-negative bacteria and MRSA is indicated. In special circumstances where you have a viral or fungal pathogen or it's suspected over a bacterial, you're going to initiate the appropriate management for that. This is another kind of summary slide from the surviving sepsis guidelines that I like. It's a quick screenshot and it kind of just summarizes a lot of those strong recommendations that we spoke about earlier on, just really quickly. So procalcitonin, this one is not really a main point in the surviving sepsis guidelines. I think it deserves a mention because there's kind of conflicting evidence and usage across different hospitals, and some hospitals don't have it at all, some do, and what do we do with it, and what is it? So it's a serum marker for bacterial infection. We should not be using procalcitonin to determine whether or not we're going to initiate antibiotic therapy, but there is evidence that supports using procalcitonin to help us shorten the duration of antibiotic therapy in septic patients, even though this is not currently in the guidelines. It can also be used as a marker to help support discontinuing antibiotics in patients who were thought to have sepsis but actually didn't. Overall, there has been evidence that shows that it leads to a decreased use of antibiotics, but there is really, like I said, conflicting evidence about the mortality benefit associated with procalcitonin testing, and it's extremely expensive. The recommendation currently for surviving sepsis guidelines is for the patients that have suspected sepsis or septic shock. They recommend against procalcitonin plus clinical evals to start antimicrobials versus just clinical evaluation alone. Next topic is going to be, our next point rather, is going to be mechanical ventilation. So for the ICU critical care people, well, for everyone in general, but more so tailored to kind of home. There's not really enough evidence currently for surviving sepsis guidelines to make a recommendation about oxygen targets or the use of non-invasive ventilation over invasive ventilation in patients that have sepsis-induced hypoxemic respiratory failure. What is currently recommended is high flow over non-invasive for patients that have sepsis-induced hypoxemic respiratory failure. And in sepsis-induced respiratory failure without ARDS, low tidal volume is recommended over a high tidal volume. What about in sepsis-induced ARDS? What do we do then? So low tidal volume still recommended over high tidal volume, and low tidal volume is at 6 ml per kg. If you have severe ARDS, they recommend that you use the upper limit goal for the plateau pressures for these patients, 30 centimeters of water over a higher plateau pressure goal. If that patient now has moderate to severe ARDS, that's sepsis-induced, higher PEEP is preferred over a lower PEEP, and traditional recruitment maneuvers are also recommended in these patients. It is not recommended to use incremental PEEP titration strategies for recruitment maneuvers in these patients. And we do recommend using, well, they recommend, not me, using prone ventilation for at least, if not more than 12 hours daily. Intermittent NBA bolus is recommended over continuous infusion, and in centers that do have the capacity to do so, veno-venous ECMO is recommended when mechanical ventilation does fail. So if you are in a center that does not offer that, this is kind of a point where we would consider taking that patient and transferring that patient out to a center that does offer that if the patient does qualify. Glucocorticoids are suggested if the patient is hemodynamically unstable despite having received vasopressors and adequate fluid resuscitation. But there is no role for glucocorticoids if the patient is septic without shock. The recommended dosage is going to be 200 to 400 mg per deciliter IV of hydrocortisone. What should we do about VTE prophylaxis in these patients? So everyone with sepsis or septic shock should have some kind of VTE prophylaxis unless it's contraindicated. Low molecular weight heparin is recommended over unfractionated heparin, and it's currently recommended against using mechanical VTE prophylaxis plus chemical over just chemical alone. So there's no need to throw SVDs on your patients who's already getting Lovenox. Lovenox is fine. Glucose control is really important in these patients too. We know that they can become hyperglycemic in the setting of sepsis, and hyperglycemia can worsen their clinical condition. So the goal recommendations now are between 140 and 150. A patient, even if they are not a diabetic and they have a glucose level of over 180, it's recommended that if they are septic, we do start glucose control on those patients. Sodium bicarbonate recommendations have changed a little bit. So it is not recommended that we use sodium bicarb to improve hemodynamics or to reduce pressure requirements in patients with septic shock and hypoperfusion-related lactic acidemia. You do use sodium bicarb if the patient has septic shock and severe metabolic acidemia and AKI. So you're not using it just to lower that lactic acid, but if they do kind of meet those criteria of severe metabolic acidemia, so pH of less than 7.2, AKI, and septic shock, then sodium bicarb does play a role in helping those patients. The next couple of slides are kind of just a synopsis. I like it because I'm going to start studying for boards. I'm only a pre-2, so maybe that sounds like a better statement, but so if you want to take screenshots, this is from MixApp for whoever is also studying for boards. But this is treatment of sepsis and septic shock in a nutshell. This is what's going to be on the internal medicine boards. I'm not sure about the surgery boards, but this does take in some of what we talked about the surviving sepsis guidelines, and just really puts it into fine bullet points. So fluid resuscitation, balanced crystalloids, LR over NS, 30 mils per kg within the first 3 hours, and then continue fluids based on clinical assessment. Vasopressors, norep is our favorite, number 1. And then vasopressin is going to go in with as number 2. You could use it as a norepinephrine sparing agent. It's indicated for persistent hypotension, unresponsive to fluids. Source ID and control, so all those things we talked about finding out what's causing the sepsis, getting it out, and then antibiotic therapy. So that 1 hour goal, start within that 1 hour if you can, as soon as you diagnose sepsis. You're going to narrow that coverage based on culture and sensitivity. Carbapenems or extended range penicillin or beta-lactamase inhibitors in most septic patients are going to be appropriate. Septic shock, you're going to do 2+ antibiotics from different classes to cover what's most likely. Hydrocortisone is going to be the 200 to 400 mg IV. That's in patients that are persistently hypotensive despite fluids and vasopressors. Your glucose control goals are going to be between 140 and 180. Once again, you're going to be adding on glucose controlling agents, so like a sliding scale, starting after 180. And then mechanical ventilation, what's important boards-wise is going to be tidal volume 4 to 8. So 6 mg per kg is really the easy way to remember it, but 4 to 8 is the goal. That's low tidal volume for ideal body weight if ARDS is present in these patients. References, so the Surviving Sepsis campaign, obviously number 1. Except like I mentioned, I like a little board studying while I'm presenting. And then I added some of the surviving, the definitions that I got. Where did I get the SOFA score? That is about it. Let me see if I can hand it back. So those are, how do I get back to you guys? Okay, I'm back.
Well,
So those are, go ahead.
I would like to start by saying that was a spectacular presentation. In addition to my
Thank you.
general surgery boards, I have my critical care boards and have practiced critical care for most of my career. I can tell you, I think that was an excellent synopsis at an elementary level that covered everything really quite nicely. I think it was articulate, in depth, and done well. And thank you very much. I learned a lot.
Thank you so much.
Listening to you tonight.
Thank you so much, Dr. Koyashi. I appreciate that. Do we have any questions? Like I said, there was 92, I believe it was 92 plus recommendations in the Surviving Sepsis guidelines. Most of the changes have been from changing the level of recommendation, so between weak to strong or moderate to weak or et cetera. Some of the things that we talked about, I tried to really just include what is new, what has now become a strong recommendation, to kind of, I guess, make it not just internal medicine related, but surgery, podiatry, et cetera, et cetera.
Well,
So whatever questions you guys have about it.
But your data is mostly internal medicine related. Most of the sepsis seen by the internists are pneumonias and urinary tract infections that cause sepsis, and dealing with biliary sepsis prior to seeing surgeons. So most of the non-abdominal sepsises are seen by you. Most of the extremity sepsises, dead toes and dead things, are seen by Arion and his colleagues. So we sort of do have divides and different perspectives on sepsis and source control, but the fundamentals that you presented were quite accurate and apply to all the specialties in terms of source control, antibiotics, the initial hours, what to draw, blood cultures and serum lactates and fluids and such. That is universal for all of us. And it's very interesting how even after a 41-year career that I've had, things that we did without knowing are now codified as recommendations. and we now do things in a granular level, when before we just did it by being good doctors and knowing to check the blood gas and knowing to check the urine output. So thank you.
Dr. Chaushay, to be more specific, the source is like 64% from the lungs, 20% from abdomen, 15% from bloodstream, and 14% from UTIs. I mean, genitourinary tract.
Yeah,
So
but
yeah,
when you say the abdomen, that probably means patients with diverticulitis and biliary sepsis.
yes, probably. What else could it be?
Well, catastrophes, I'd like to think we
Rupture.
see immediately and don't fall into your net.
Yeah, like peritonitis and yeah.
Right.
Okay.
I'd like to think. I could be wrong.
Yeah.
And as my ex-wife would say, I'm often wrong.
Well, Nora, that was excellent presentation, and me reading
Thanks,
about
Nora.
this. Yeah, it just like took me over because, you know, we don't do much of the reading, but the presentation was great. Thank
What
you
does
so
our
much.
intellectual say? Edion?
I'm
Edion?
here. I'm listening. I'm listening.
What do you think?
I agree with the above guidelines. The one question I had is what damage are the compressions, or I mean the Venadines have? It was mentioned that you don't need Venadines, but just Lovenox for DVT prophylaxis. I mean, these are bedbound patients for weeks. We put our surgical patients on either heparin or Lovenox for DVT prophylaxis, and we put the Venadines on. I'm surprised why they took the Venadines off on the sepsis guidelines.
I don't think she said that they cause damage. I thought she said, and the guidelines reflect that they were superfluous and unnecessary.
So I think part of it too is not all of these patients that are coming in are having DVT studies done. So if you're throwing on, and I might be wrong, but if you're throwing on now mechanical prophylaxis like an FCD to a patient that has maybe an underlying DVT, as opposed to just chemical prophylaxis alone, you might be running the risk of theoretically throwing that clot in a patient who's already hemodynamically unstable.
That's incorrect. There's no association between DVTP and having the Venadines on.
So there are studies that were done on Lovenox, which is enough, more than enough actually, to prevent any DVT. So it's just not necessary to use the venous compression.
The Venadines, in addition to having the normalized muscle tone to pull back the venous blood and prevent venous stasis, they also release TPA on the tissue. So that in and on itself helps with coagulation factors. I don't know of a surgical patient post-operatively not being on Venadines and heparin sub-Q or Lovenox. But just the combination of those two, prevent DVT and PV. It has been shown time and time and again. My question was, why was that omitted on these sepsis guidelines? I thought maybe there's a strong reason for that.
There is not, Edion. I've read those guidelines carefully. There is no strong rationale for it. And much of the guidelines, I will tell you, having read them carefully, they are weak recommendations, not based on solid evidence. Sadly, that's where we are today in our approach to sepsis. We have weak recommendations based on inadequate data, based on poorly designed studies, but it's the best we have. So we just keep on trucking. That's all we can do.
Yeah, but having said that, it was a very presentation. Very well presented.
Yeah, really nicely done.
Thank you. Thank you.
I don't know which Nora did the nicer presentation. I'm voting for Nora too, but that's me.
It's like a Nora squared thing, you know.
Okay, there you go. You got me.
We can definitely give Nora to the medal.
Exactly.
Yes.
You guys are being nice to the residents.
It's so nice. Yeah, this was great.
We
So
are
if-
honored to have our residents here. We
Yes.
want to help you. We want to be here as mentors for you and people that can help you in any way, either get a job, get a new position, or whatever we can do. You can use the senior people here as resources. Yemi Shiptad that came before you. So, I went to Hopkins in 1975. I understand there's a girl there now. Boy, I'd love to. There she goes. I thought that would be you, and I'm so honored that there's someone else there 40 some years later. So we have to keep pulling each other up and honoring each other in doing that. You and I have to do a session together. You pick the topic. You pick the topic.
My current work is actually on continuous subcutaneous insulin infusion pumps and using them perioperatively in anesthesia. So that's kind of what I've been working
I'm
on.
a diabetic. I'm your hero. I'm your hero. I have a subcutaneous pump. I could.
Which one?
I'm a Dexcom guy.
Okay. Do you also have the continuous glucose monitor with it? The
Omnipod right here.
there you go. That's right.
Never go home without it, like my American Express card.
Yeah, so we're basically trying to work with people at Hopkins and the perioperative center to make sure that those pumps aren't getting turned off for surgery, because a lot of people are afraid that these patients become hypotensive, but in fact they become hypertensive post-op, and then they have problems with wound healing and infections and all these things. So it all comes back to that.
Really? I didn't turn mine off and I got no infection. And I had the same fears. Okay. I'm glad I wasn't alone. Very nice to meet you. And I'm proud of you.
Thank you. Thank you.
Well, I think we can conclude this Zoom meeting. Thank you for joining us. Yes, until the next time. I would like, it's like a new year for AAMS. I would like to ask everyone to tell people they should join us. The bigger we become, the greater it is, and we can help people planning for a lot of health fairs. And our next event, AAMS next event, meet and greet, is going to be end of September. So
Where's it going to be?
This time it's going to be in, we're thinking Westchester.
Excellent.
What do you think?
I love Westchester. I like that priest at the church. I think I need to see him a few more times so he can forgive me for being a pagan.
It's in that, yeah, that was in Hartsdale, but this is where we're looking at the venues. We're thinking of Westchester. It's parking is available. They have bigger venues and places. So yeah, end of September. Okay, and we're gonna try to
not where the restaurant was.
No.
You needed a bodyguard to get out.
Yeah, no. It's
Okay.
yeah, it's gonna be better this time.
Excellent. And by the way, sometime in September, there will be an exhibition in the greater Boston area about Butrint that's being organized. And I wanted to share the information for that. And I may not be personally there in September. I've accepted a position, I don't know why, as the founding dean of a new medical school in Albania.
Oh,
So
where's this school, Dr. Chaushai? In Tirana?
in Tirana, they've created a university called Western Balkan University. It already has a school of nursing and a school of imaging and 2 or 3 other colleges. And Cambridge University in London is helping them establish an English-speaking medical school in Tirana. And we're going for government approval for this school, which will be run through Cambridge. The professor at Cambridge was once one of my students, who's now going to be my boss, although I will be the dean in Albania. He will be the person in Cambridge. And we're going to try to attempt an experiment of an English-speaking medical school in Albania. It will probably fail like many of the things I've done in life, but I'm going to try it. I'm going to be interested to speak privately with Edian, whose father was once dean at Chasut, and see how his thoughts are in this matter. So I'll be coming back intermittently coming this September, but I'm gonna die fighting.
Absolutely.
So that's
And
what,
you're not gonna fail, that I know. But we're here for any help, you know. I mean, we are about 110 members now in
well,
AAMS.
and that's what I was hoping, that we
Yes.
could Zoom lectures from our American faculty into the lecture halls in Albania that could help give a different perspective to our students. The students will all be Albanian. They will all speak English. And the faculty I will select, and they will all speak English, or they will not be selected. And we're going to make it different than Chasut. There will be no sexual harassment. Lectures will occur when they're supposed to occur. And so many things will happen that don't happen now. So we'll see how it goes. And I'm looking forward to fighting one more battle.
Absolutely. That's great. Wonderful. We're
Thank-
so proud of you, Dr. Choshai.
I'm just trying to get out of town before they arrest me. So thank you very much. Falim derit.
Thank you, everyone. Hope to see you soon.
Good
And
night.
again,
Jan, call me someday. All right, guys.
all right. Okay. Have a good night.
Thanks, everybody. Good night.
Good night,
Good night.
everybody.
Good night.